general anxiety disorder. So you had this in ClinMed. Have you done this one?
Mm-hmm. Yeah.
Okay, so what have you learned about it? What? Common? Did you say? Okay, very common.
And it's very general, like the name says. It's not specific anxiety against one thing. It's
right.
Just generally.
So has anyone in here never experienced anxiety? So common to the, so it's very common, right? Have you not?
That's good. I mean, not really. Like I was doing the GAD 7 and I picked none of the answers.
Wow, you are unique, which we knew. In a good way. In a good way. Okay, so the majority of people have experienced anxiety as part of just human condition, right? Okay. When would it be a disorder, though? When do we start looking at it as a problem?
When it impairs function.
When it impairs function. Okay, so when it starts to get in the way of people's ability to do their job, task of daily living, their work, their relationships, all of that is important. Okay, so the drugs that have been found effective are the antidepressants, so you should go, yay, I don't have to learn another group. I already know it. I can apply it to another place. Right. The anxiolytics, we haven't talked as much about them. Benzodiazepines and Buspirone. Anticonvulsants, pregabalin, you've had a preview of that. The antihistamines, hydroxyzine. And the second generation antipsychotic, the one that's listed is quetiapine because it has data behind it. So the first line are the SSRIs or the SNRIs, either one. In terms of efficacy, they're very effective. They are 60 to 70%. So there is still a significant number of people who won't respond to them. But because their side effect profile is fairly well tolerated, they don't have addiction potential or dependency potential, they have risen up to the first line. So when selecting them, you want to base it on the drug's side effect profile. So what are the big side effects we worried with the SSRIs? Say it again. Hypertension, hypotension, orthostatic hypotension. Okay, let's go with big categories. So what's probably the biggest category of the side effects? CNS. Most common. So lots of CNS side effects. Sexual dysfunction was on there, weight gain. What else? GI is big. Remember the gut serotonin receptors? So when you're studying this, you should have your handout from antidepressants with you. So Dr. Britton told me he wants me to write 8 to 10 questions on antidepressants that'll be on the next test. Did he tell you that?
No.
Surprise. Okay. Because he wants you to bring it forward. Okay. Drug-drug interactions, there aren't that many. But remember, a lot of these people are going to have other psychiatric illnesses or conditions, which will, remember what pathway do they go through? 2D6. Most of the drugs that affect psychiatric illnesses or conditions go through that pathway. So there's liable to be drug interactions. And then patient's treatment history, if it has worked in the past, it is well worth bringing forward and using it again. If they say, I took it and it worked, but I couldn't afford it, I quit refilling it, for whatever reason. I had this side effect, but it was okay, I could tolerate it, and their preference. Preference can go down to whether treat or not, okay? Treat and do psychotherapy. So through here, have y'all talked about cognitive behavioral therapy? Good. Okay, so if you're using CBT, it's often equally effective with the drug therapies. Sometimes in combination, people do even better. We'll talk about that as we go through. So place in therapy. Antidepressants are best on the psychic symptoms. So the worry, the concern, apprehension. When general anxiety disorder and depression overlap, which they commonly do, then using an SSRI or an SNRI is preferred. Okay. We always prefer them over the benzodiazepines because of, again, addiction and dependency. So the trials, the SSRIs that have been shown to be efficacious are the most of the SSRIs. The only one that's not on there is fluoxetine. So I have given you a list on probably a page or two over with all the doses. I'm not going to ask you those. They're there for you in case we use them in the cases and for your reference. The SNRs, there's just two of them. There's venlafaxine, the extended release product, and duloxetine. So next page under administration, the doses are pretty similar. In some places you will see that they will go with even lower doses. So the lower doses are preferred because these drugs can be activating, so they can worsen anxiety in the beginning, and so we use the lowest dose possible. In your elderly, always think lowest low. What's the lowest I can start on? Again, meaningful action or time is 4 weeks, 4 to 6 weeks, so keep that one in mind, it's important. And it's also important to tell the patients. This is what you should expect. Some will respond very quickly, and that's good. Some people, if there is not a reaction, will advance drugs even faster. But you have to be careful because then the side effects, unwanted side effects, sometimes can then pop up. We're going to go through the drugs, and we're going to walk through how to apply them. The second line would be the anxiolytic Buspirone. I don't even think Buspar is made anymore. I think it's all gone generic. Do you see Buspar in the
Not
pharmacy?
brand name, but generic, yeah.
Right. So the Buspar is the old brand name, and they don't manufacture that anymore. Okay. So it's a weaker anxiolytic than the benzodiazepines, but it has no dependency potential. The time of onset is longer. There's nothing faster than the benzodiazepines in terms of relieving symptoms, why they become the drug of choice in acute. But in chronic, we would go with other agents. So they're largely used to augment. Remember how we use bupropion to augment antidepressant? Don't get those two confused because they're very similar in name. So Buspirone is used to augment antidepressants in terms of anxiety. So if you have someone who can't tolerate, maybe they're getting a partial response, but they can't tolerate side effects and you can't advance the dose, you could add this. You get somebody who's not responding to even 1 or 2 different antidepressants, you could add this on as an augmenting. It can be used by itself if you have reasons why you can't use the SNRIs or the SSRIs. So it can be used by itself. Again, 4 to 6 weeks, so it falls into that. So all of them are going to fall into that time frame except for the benzodiazepines. It is a serotonin 1A receptor partial antagonist. Typical side effects, usually it's fairly well tolerated. Insomnia, agitation, nausea. Pregabalin is an anticonvulsant. It's very similar to gabapentin that we've talked about, Neurontin. This one's called Lyrica. The other two good things about the antidepressants and Buspirone is that they're not scheduled. So you don't have to worry about that hassle. But Lyrica is a Schedule 5. It is also used to augment. Very low tolerance or withdrawal or dependency. And better tolerated than benzodiazepines. The major problem with pregabalin is sedation. So it can be used as monotherapy in non-depressed. So when you're looking at somebody who has initially diagnosed with GAD, one of the first things to ask you is, do they also have depression? Okay, so that shunts you to the antidepressants right off the bat, as long as they don't have a contraindication or an intolerance of them. If they are not a depressed patient, you could look at one of the non-SSRIs or the non-SNRIs. So you could go Buspirone, you could go pregabalin. Okay. So a lot of it depends on matching it up with what is going on with the patient. So again, what are their other conditions? How old are they? What are they at risk for in terms of side effects? That helps you choose. And then a lot of what will drive your initial group of drugs you can choose from will be what the insurance will pay for. Okay. All right, page 6, the benzodiazepines. These are all Schedule 4s. There are probably more to add to this group. These are the most common for GAD is alprazolam, very common, lorazepam, diazepam, I'll talk about that, and clonazepam. So these are the 4 most common. They're equally efficacious, but they are really different in terms of their half-life, their propensity to have symptoms if you take the drug away quickly. You can use them acute because they're rapid in onset. You can use them for maintenance if you have somebody who has a very low potential for drug abuse. So they can be used by themselves or an adjunct. Often they're used as adjuncts. Okay. So most commonly they're used early on when you're putting somebody on an SSRI or SNRI, and they either in the past have had it or they're very high anxiety, or you really need to get their anxiety under control, then that's when you would add a benzo. So I'm telling you, that is an important concept to keep in mind. Okay? So we can use it short term. The problem with the benzos is they are great off the bat, and they're very effective, but they take forever to taper off. And people get very anxious about taking them off. So they have anxiety about them going away. And they also, you have to taper them over long periods of time, weeks to months, depends on which drug you use and how long they've been on it. Okay. So what are they effective at? The somatic symptoms and the autonomic symptoms. Okay, so the somatic, the restlessness, difficulty concentrating, irritability, muscle tension, sleep disturbance, calms all that way down. The autonomic symptoms they have, shortness of breath, palpitations, very similar to panic attacks. Did y'all talk about panic attacks today? Okay. Okay. They're very good if you've got somebody who is so anxious that they can't hear you, they can't talk to you, in meaning that their anxiety is overwhelming them. You can use a very short-acting benzo to bring them down to a point where they can listen to you. So they're very effective that way in tamping down the emotional symptoms that the patient may be having. Okay. So the biggest problem, if you were here 20 to 30 years ago, you would have fewer drugs to learn, but you would also, benzos would have been the drug we would have been talking about as drug of choice. But tolerance, dependence, now we got other drugs that are better and equally effective that we're using. Okay. So know these. Who is a candidate for long-term low-dose benzodiazepine treatment? If you put people on benzos that are poor candidates, they are going to dog you and be the bane of your existence. So choose wisely. So patients with chronic CAD, they are can be on it. Minimal current depressive symptoms, okay, because there you could use it as monotherapy. No history of substance use disorder. No tolerance to their anxiolytic effects. Okay. Well, because with tolerance comes upping doses, using longer acting agents. When they are tapered off, they have just minimal withdrawal effects. Okay. So those are people good candidates. Who are the poor candidates? If they've got a history of substance use disorder, be very careful. People who get rapid tolerance, because they're just going to want to escalate that dose right on up. People who increase their dose against your advice. And those that have withdrawal symptoms in between doses. Okay. Your tolerance, the patients who are tolerant will have that same trouble. Okay. Pharmacology, these drugs are going to work on GABA receptors. So remember, GABA is the main inhibitory. So GABA inhibits excitatory neurons. That's why when you start tapering them off, those excitatory neurons and nerve fibers that's what gives them their symptoms. Okay. Flumazenil is a benzodiazepine antagonist, so just kind of keep it back there as it's an antidote. And it will quickly reverse the effects if someone's had a benzodiazepine overdose. For the most part, people don't get into trouble with benzodiazepines and overdose unless they mix them with alcohol. Or you give it to somebody who's got liver or renal impairment. An older patient can get into trouble quickly with some of these. The kinetics are the big differences. It will be why you choose a drug over another. So let's walk through these bullets. So those that quickly distribute, particularly into the brain, usually have rapid onset. Lorazepam is one of them. Valium's very quick, but it's a very long-acting. Persistence of the drug goes to elimination half-life. So the longer the half-life, the longer the effect of the drug will stay around. Valium lasts forever. Librium, which we don't use very often anymore, chlorodiazepoxide, lasts a long, long time. Ativan, very quick. Midazolam, very quick. So persistence in the body governs the timing of withdrawal onset. So if you have somebody on a very long-acting drug, they're not going to go into withdrawal symptoms very, very fast. Valium, much easier to taper because they don't have the withdrawal symptoms. The drug hangs around the body forever. Lorazepam, alprazolam, very quick. You start withdrawing, they have symptoms right away. Alprazolam, when we get to that, we'll talk about it with panic attacks. It's terrible because if they are not taking it on a regular basis or as they're supposed to, the withdrawal can be life-threatening. They can develop fatal, very significant seizures. So rapid and short-acting drugs, you always need to tell people, do not stop abruptly. Okay. So shorter half-lives, lorazepam produce acute withdrawal on abrupt cessation. The ones with longer, Valium, clonazepam, more delayed, somewhat attenuated. So they're just not as strong. The patients can usually tolerate them better. Okay, so that concept you need to have. It's a very diverse group. They all act the same, but they're in terms of how long they do it and how quickly they can do it is important to differentiate. So acute drug reactions with the benzodiazepines. Some very significant. A lot of them are central. A lot of them are psychic. A lot of them are long-term, and they can cause cognitive deficits over time. So psychomotor retardation, drowsiness, poor concentration, mental confusion. Wait, I thought that's what we were trying to get away from. Well, with long-term and too high of doses, that can happen. Ataxia, what's that? Lack of muscle coordination. Muscle weakness, diplopia, what's that? Double vision, vertigo, dizziness. We'll use it for dizziness. So they slow reaction, time impaired driving skills. So when we get to the drugs that we're going to use for insomnia, we have to warn people. In the day after you take it, you may not be able to drive right. Memory impairment, antegrade, I spelled that wrong, amnesia. Okay, so that's why we use midazolam when we want to put you to sleep for a procedure, because you won't remember it. So we take advantage of that. Impaired episodic memory, so remembering recent events. So keep this in mind when you are interviewing, especially like an older person or somebody who's been on a benzodiazepine. The circumstances under which things occurred, they may not be able to tell you correctly. The longer they've used it, the more those deficits are, or more pronounced those deficits are, especially in visual, spatial ability, and sustained attention. So there's good reasons they're very effective when used correctly, but it's more like you want to use them and then you've got to get them off. Warning patients. We're going to use this. This is going to help, but then we're going to taper you off of it because we don't want these long term. Paradoxical disinhibition. So sometimes what happens is they are, instead of having a sedating effect, they have an agitating effect. And you can see these: aggression, hostility, impulsivity, rage, violence, antisocial. I don't know if that's so much tied to an underlying disorder as well. It could be like with mania. Emotional blunting, emotional anesthesia is a term you'll see used in the literature. Effects on pregnancy, you don't want to use them in pregnant women. The class D is an old classification. That is a very teratogenic. It's not as bad as warfarin or alcohol or the retinoid products, but it's likely, very likely to cause some type of defect in the infant. Crosses the placenta, develops dependence in the child, and breastfeeding. So you just don't want it anywhere near an infant. Dependence. These are important to know the symptoms of withdrawal. So again, the shorter the half-life, the faster the action of the drug, the more significant the withdrawal symptoms are, and the faster they occur. Okay. If you're rapidly decreasing, if someone's taking themselves off of it, they may land in your emergency room because they've got withdrawal symptoms. Oh, I put the symptoms in another place. Sorry, we'll get to those. Okay, so those are the big side effects. Withdrawal, they're down through here. So some withdrawal from some of these agents can be life-threatening. Alprazolam is one of them. Usually the higher the dose and the longer they've been using it, and that short acting is where they're going to get in trouble. So the signs and symptoms are under that third bullet: tremors, anxiety, perceptual disturbances. Those are more common. Dysphoria, psychosis, seizures. So keeping in mind benzodiazepines as a potential cause if somebody comes in and they decompensated would be helpful. Okay. Short half-lives, you can see this within a day or two. In the long half-lives, it may be weeks to months, and they usually don't have it as bad or is the more significant. Those last three bullets kind of go together. So the chronic use of a benzodiazepine changes the nature of those GABA receptors. So how that then in the behavior you see in the person is tolerance. So they need more drug. When the benzos are removed, then you've got that inhibitory effect removed from excitatory neurons I referred to earlier, and that's when you get that pro-excitatory state. So that's where you link it back to hallucinations, psychosis, seizures. So you can avoid or minimize this is gradual tapers. Now, I think on the next page I've got an example of them. So you go with very small doses over long periods of time, reducing the dose. The other is that you can convert or put them on a longer acting and taper them off. But it can take weeks to months to get somebody off of benzodiazepine safely. So if you look at the top of page 9, individualize the taper, go slow, gradually. This is one approach. 10 to 25% reduction of the dose every 1 to 2 weeks until the lowest dose is reached. But you may even have to slow that down for patients. That may be too fast for some, and especially on the short-acting ones. The longer-acting people will, like Valium, they will do fine. Clonazepam, this kind of approach would work. Monitor for symptoms of withdrawal. If the patient has if you've tried to taper before, then tapering over a longer period of time. I've seen this on people who've been on drugs for insomnia for a year or more. When you try to take them off, they quickly relapse. So in going back over a 4 to 6 month taper sometimes is much more effective and keeps them out of trouble. There is some evidence that if you augment taper with behavioral training, patients do better. Okay. So the benzodiazepines, on page 7, if you go back a couple on that table, I've given you the doses for initiating and titration. I'm not going to ask you those specifically, but if you look at that table, you can see they start with very low doses and move them up to as it's needed to control symptoms. Okay, we'll finish this page and we'll take a break. The other drugs that can be used, remember that one of the atypical antidepressants is mirtazapine, Remeron. It's a very sedating antidepressant, so if someone who has trouble with insomnia and their anxiety, that might be a good one to try. Another one is Withdrawal, very commonly used. This is an antihistamine. It's very sedating. So again, in somebody who has insomnia along with their anxiety. This one, it can be used in a non-depressed patient. It's a frequent go-to because the side effect primarily is sedation. It's cheap, it's easy to use, there's no dependency with it, and it's fair. It has a fair degree of effectiveness. The biggest thing would be anticholinergic side effects, so be careful of it in your older population. Second generation antipsychotic, this would be quetiapine. This would be your drug of last choice. If everything else has not worked, then you could go with this. Keep it in mind. But the side effect profile is so high that you are not going to want to use this unless you're forced out of all the other categories. Okay, questions? All right, let's take a break. Did anybody talk about bringing the fans over? I could have the fans brought over tomorrow. Huh?
Laura said next week we might just end back over there.
Oh, really?
When we saw Mrs. Dillon.
Okay. It's very cold down there. It's like a refrigerator. So, well, it keeps you awake. Okay, we'll start back a little after 4.
That's why I'm like, if it's already ready.
I like the windows.
I do like the windows.
Yeah, I do like the windows. Actually, I like this. For Indo, it would work.